Hey, good morning, everyone, and welcome to Euronurse. I'm your host, Vic Sinise. If you're watching us live, we come to you live every Saturday at 9 a.m. Central Time. Welcome to our show. Be sure to put in your comments in the comment box if you have any questions or comments that you want to add on to the show. If this is your first time visiting us, be sure to check out our website at euronurse.com. Best place to learn more about the show. Also, best place to go to see all of our past episodes. We keep them all on demand, all 89 of them. And hey, if you want to listen to us in your car, no problem. Just go and check out our Euronurse Plus area, and you'll find our audio podcast available there. So you best place to go to find us for audio podcast. If you're a patient watching this show, welcome to the show, but there's a better place for you to go. Go to europatient.com. Every Saturday following this show at 10:30 a.m., we have an episode, so check us out. We also have all of our episodes on demand available on that channel. If you're not getting our e-news, what are you waiting for? Check us out for on our website to register. Quick and simple. We use MailChimp, so your email address is never sold or distributed to nobody else can see it. So it's perfectly safe. All right. This week, I'm going to be talking about one of my favorite books when I was a kid growing up, Fun with Dick and Jane. Well, Dick and Jane are growing up a little and having some different fun, and we're going to talk about some of those problems that can pop up with Fun with Dick and Jane. But right now, let's bring in our experts to the show. Experts, and I think we'll get you all in here now. I did it. Got everybody on.
Good morning.
All right. So, yeah, Fun with Dick and Jane today. No fun stories to tell for me because since I'm giving the talk, I've been practicing everything I need to know about STIs, and that's another one. Why do we change the name so much? I can never understand. It was when I was growing up, it was VD, then it became STD, now it's STI, and it doesn't roll off the tongue quite as easily. But what am I going to do? It's progress, right? All righty. Hey, Andrea, welcome to the show. I just saw you sneak in there. Why don't you go ahead and give your introduction?
My name's Andrea Strong. I'm a nurse practitioner. I work in Wisconsin, and I've been working in urology since 2010. I worked as a registered nurse. I did inpatient, I did outpatient, a little bit of clinic work and triage work and procedure work. So I've done just about everything that there is to do in urology. I'm also certified as a urology nurse, and I'm the educational director for the Chicago Metro chapter, and I'm also on the board of directors for National SUNA. Thanks.
And thank you for being one of our experts. John, go ahead and do your introduction.
Good morning. I am passionate about helping urology practices succeed so they can reach maximum clinical and financial efficiency. To that end, I created the Thriving Urology Practice Facebook group where we crowdsource practice management solutions for everyone's benefit. I frequently speak on topics of coding, billing, revenue cycle management, marketing, and how to run your practices more efficiently in the era of declining reimbursement and rising practice overhead. I'll be speaking at the AUA annual meeting in a couple of weeks, Texas Urologic Society meeting in June, Louisiana Urologic Society in August, South Central Section AUA meeting in October, and Urology Advanced Coding and Reimbursement Seminar in December. I'm John Lynn, a lowly private practice urologist in Gilbert, Arizona, and I look forward to our discussion today.
All right. Thanks, John. And you're not lowly. One of our favorite speakers they have available, our experts. And then finally, Lori, go ahead and introduce yourself.
Good morning, everyone. My name is Lori Atkinson. I'm a certified urology registered nurse. I have been working in urology for 26 years now. And I work for a urology practice in Geneva and Winfield, Illinois. Well, I don't have a fun story, but I'm sure this lecture on Dick and Jane might be a little fun. So I'm ready to learn from you, Vic.
Yeah, it's definitely going to be fun. A couple of times I had trying to get different slides together for it and different thoughts of how I'm going to present, and I got to tell you that I was having more fun cracking myself up. So we'll see how it goes. Anyway, let's get on with our show. I'm going to bring a few things in here. Let's see. I think I got everything set. Hey, it works. All right. So, yes, we're going to be talking about Dick and Jane. They have lumps and bumps, sexually transmitted infections. And let's get on with our show. So, meet Dick. Meet Jane. Dick meets Jane. Well, they get together and decide, let's go out for a few drinks. Uh-oh, looks like it's getting a little late. Dick offers to take Jane to his place so she doesn't have to travel so far. Nice of Dick, isn't it? Mix of alcohol and hormones, and oh no, Dick and Jane have unprotected sex. You can see where this story is going. A couple days later, Dick goes to the clinic complaining of burning from his, you probably thought I was going to say dick, right? No, from his member. Yes, he's got burning from his member. And we know he also has a green discharge, typical symptoms of gonorrhea. Green discharge, yellow discharge sometimes. About 10% of males and 50% of males, however, have no symptoms whatsoever. A quick gram stain, and we can see these gram-negative diplococci, presumptive diagnosis, gonorrhea. Now, gonorrhea is often referred to by the names the clap or the drip. It's transmitted through unprotected vaginal, anal, or oral sex with an infected individual. Now, I could understand where the word drip comes from because of that discharge that you get. But the word clap, I mean, I'm not that old, so I don't really remember some of these origins, but I had to look it up. So for those of you that know it, you're beating me in your trivia. But if you don't, this could be a good trivia question. It comes from the French word clapier. I don't know if I'm saying that very French, but clapier means a brothel in France. So, it makes a lot of sense now why they called it the clap. Well, Dick and Jane aren't such a happy couple anymore. Dick blames Jane, Jane blames Dick. But again, as I said, 10% of males have no symptoms, 50% of females have no symptoms. If Jane had symptoms, it would probably be an abnormal discharge from the vagina, pain or burning when she urinates, and maybe some bleeding between her periods. Dick's symptoms very similar, abnormal discharge, as we spoke about from the penis, burning when he urinates, painful or swollen testicles. However, that swollen testicle symptom is less common. Most of the time when I see patients come in, it's the complaint of that discharge. So how do we treat gonorrhea? Well, there we got that big needle ready to go. And that is the CDC's current recommendation is a single dose of 500 milligrams of intermuscular ceftriaxone. Now, I give a lot of ceftriaxone as a preventative, a prophylactic dose for our prostate biopsies. I can tell you one thing, you can want to give the patient their penance along with their cure, mix it with water, sterile water. If you want to be nice, mix it with lidocaine because it does hurt. Now, I'm old enough to know the old treatment because I gave plenty of that in my day. It's 1 gram of probenecid orally, followed an hour later with 4.8 millions of procaine penicillin IM. So each syringe holds 1.2 million units, which means 4 syringes. That's 4 deep IM injections of a very painful injection. So these patients really paid the price for what they did. You might wonder why the probenecid is used. It has the ability to block the transport of organic acids such as penicillin across epithelial cells like the renal proximal tubules. When used with penicillin, it results in a higher blood level and longer duration of the antimicrobial. So it makes penicillin into super penicillin. And as I mentioned, you get your penance with that one. So I also think it's probably a big deterrent about ever, getting unprotected sex again. Dick will take a little more care with Jane. It's not the most common one that we see. More common in our area is chlamydia. It's transmitted the same way, vaginal, anal, or oral sex with an infected partner. It can be passed on from a mother to her baby during childbirth. You have some more serious complications that we worry about. And if left untreated, chlamydia can cause serious health problems such as pelvic inflammatory disease, which can lead to infertility in women. And in men, it can cause epididymitis, which can also lead to pain and infertility. So it should be treated. The best way to test for this is when you have a patient coming in with complaints that you think could be of that age group, get a 2 a double voided sample of urine. So the first sample is urethral wash. The second one's your bladder wash. The urethral wash, if you kind of hold up that cup and look through it, we have clear cups that we use so you can see through them pretty easily. You'll see that white strandy stuff in it. That's usually a pretty good indicator that they may have chlamydia along with their symptoms. Also, that's the sample you want to send off to the lab for culture. We usually do that new DNA culture, which will detect all the STDs that you can dream of. Also in the old day, and I'm old enough to remember that, we used to do urethral swabs. You take a Q-tip and put it down somebody's urethra. It also kind of made them not want to have unprotected sex again. But very simple test. And the treatment, the CDC came out with their latest guidelines. Now it's luckily for them, they can go to the pharmacy and pick up a pill. It's doxycycline, 100 milligrams twice a day for a week. If they're allergic to doxycycline, they can take azithromycin, 1 gram a day, followed by for the first dose, then 500 once a day for 2 more days. The old one we used to give everybody was Levaquin, levofloxacin, 500 milligrams once a day for a week. It can be used as a single dose. But sometimes they're getting away from the quinolones because of the resistance now. That's why the new recommendations. Our story continues. If you don't recognize this guy, I'm a Chicago boy, so I know all about Al Capone. Al Capone was the big boss here in Chicago. But before he became a boss, he was a simple bouncer at a brothel. Yeah, that clappy A. And that's where he contracted syphilis. Al Capone was, kind of a, too good to go to a doctor kind of guy. So he never did go to a doctor for it. And, even if he did, penicillin wasn't around, which is the treatment for syphilis. So he probably wouldn't have been cured anyway. But Al Capone did what he did and just ignored it. Syphilis did what it does, and it went away. So most of the syphilis is going to go away in a couple of weeks. Now, Al Capone never went to jail for being a mob boss. He went to jail for avoiding paying taxes. So tax evasion got him put to jail in Alcatraz, of all places. I went on a vacation to Alcatraz, so I got to see some of that trivia of Al Capone there. But that's where he got sick with actually third stage syphilis by the time he contracted or showed symptoms. And at that time, they did try to treat him. They tried crazy things like gave him malaria, hoping the fever would sweat it out of him. It didn't work. They did give him penicillin because it was finally around, but it was too late. Caught in late stage, it was very difficult to cure. So he suffered from neurosyphilis. He went crazy and insane. And he was actually then let out of jail because he was so nuts and went home and died. But when Al's lesion first showed up, it would have looked like this thing that we see right here called the chancre. And that's when it's the most highly contagious. It looks like that. Interestingly, syphilis, which for the longest time was on a real downturn, is actually up almost 50%, more cases now. So it's starting to make a resurgence. But when it's like this, it's highly contagious area. Now, of course, you'd see something like that on the penis, you probably wouldn't miss it. But intravaginally, you're not going to see it. And that's how you can get infected. It goes away in about 2 to 3 weeks, as I mentioned. So that's why Al thought he was cured. But then secondary syphilis can show up as a body rash, typically palms of the hands, see it on the feet, sometimes whole body rash. But that's usually the signs of a secondary syphilis. But of course, it looks like a lot of other things. So sometimes it gets misdiagnosed. And if not treated, often will disappear for years, just go away. So again, thinking that you're cured. Diagnosis for this is typically by blood test. And treatment is a single injection of a long-acting penicillin G, which can cure the early stages of syphilis. They can give up to 3 doses, or generally recommend up to 3 doses if they think it's latent syphilis or they don't know and they want to treat it as latent syphilis. So pretty easy to cure as long as you get to it. Make sure you're treated. Now we continue our story. Our next story is a cautionary tale of Goldilocks and the 3 Chicago Bears. Yeah, I can't help but get those Chicago references in there. Now, these 3 would soon learn a lesson. that one night with Goldilocks meant a lifetime of Condylocks. So that's exactly what this is going to be, genital warts. So we see right here, this is what those warts look like. Often they're just a few tiny small warts, so you don't see them as easily, but it's condyloma acuminatum is due to the human papillomavirus, HPV, subtype 6 is what we usually find for genital warts. It can be treated, but it can't be cured. That's why the lifetime of. You're removing the wart, but you still have the HPV virus in your system. Sometimes it can even go dormant on its own and disappear, but you still have it. It can pop up again later. So needs to be treated. Now, one of the things that we do to better investigate it, like I said, sometimes you'll just see a couple of small warts or you're not really sure. You can do something called the vinegar test, or better known as the aceto white test. And what it is you put a 4x4 wrap around the penis soaked in, household vinegar. We can always tell when we're doing one of those tests in the office because vinegar is pretty potent smell. But anyway, acetic acid wrapped around the penis. And then you go back in and you look, and you can see what happens here is it turns the warts kind of a lighter color. This is some penile warts that were sort of flat, but showed up better with the aceto white look. This is a cervix on a female. The only place you'd find a cervix, right? And these are the same thing. They treated it, and you can see those warts kind of lighting up white. So it really is pretty dramatic. If you're watching live and you do the aceto white test in your office, put it in the comments. It'd be interesting to know who's doing it not. So the treatment, why I came with a little, and I didn't make up that ditty, by the way, with Goldilocks and Condylocks. One of the reps from the company that sold Condylocks told me that one. But the treatment is Condylocks or Eldara. We use Condylocks first. If it doesn't work, then we try the Eldara. It's interesting, and I kind of put the treatment regime on there. This is one of those treatments that you really need to educate the patient. They put it on twice a day for 3 days. Then they discontinue for 4 days. That's a 1-week cycle. They can do up to 4 of those cycles till the wart disappears. If it doesn't, then they need to come back and see them. Now, here's the big warning, because I've seen a lot of these cases. Guys will put way too much on. They don't let it dry, and they let their penis flop down onto their scrotum while it's still got wet Condylocks on it. And that then burns the scrotal skin. Scrotal skin will get bright red and burn pretty easily. So let them know just to put the smallest amount, a little dab will do you. Sometimes we use a Q-tip or even a toothpick if it's really small, just to apply just enough and let it dry, and then it's safe to kind of go on. But yeah, if you see one of those burns, it's pretty bad. Some guy was just came in, his whole scrotum was beet red. He wanted to get rid of this in the worst way. Now, a lot of times the warts are so big and so vast that the medications really can't do the job. And unfortunately, I've seen several of these cases where men have just kind of let this go, not treated it. And I've always often wondered how anybody would have sex with somebody that had a penis that looked like that. But anyway, that's not for me to judge. But the treatment at this point now becomes more surgical. Cryotherapy, laser therapy, electrocautery, fulguration, or excision of these warts. And we do a lot of these as electrocautery fulguration in the office. Not probably this bad, but some that are maybe half of that amount. But one word of warning, there is some good studies out there where they have found that if you're assisting with the removal of warts, especially where you're doing a burning, like a laser or electrocautery, that HPV can be floating around in the smoke and you can inhale it. So you need to make sure you have a mask or a smoke evacuator in the room so that you're not inhaling it. And actually, there was a study that was conducted in Denmark in the dermatology and gynecology department, where they looked at anybody who was experienced with working on genital wart removal with the CO2 laser. They did nasal swabs, and then they did oral rinses, or they did both. And what they found is 6% of the people that were doing these procedures actually had HPV identified. So it is a risk. There has been reports of condyloma of the nose, and it was in somebody who was a healthcare worker who was helping and assisting. So proper OSHA required gear. Another one that's in our foray of sexually contagious diseases is this one, which I've seen a few cases of, molluscum contagiosum. It's caused by the pox virus, and it results in an infection. It can be sexually transmitted, although it's not always sexually transmitted. So it's not the only way it can get it. So people that have never had sex can sometimes get these. They look a little bit to me like herpes, but they're not. They're kind of filled with a little cheesy solution rather than a clear solution. The treatment for these is actually pretty simple because you don't even need to give them a local. You can take a scalpel blade and kind of turn it on its side and just scrape them off. They just pop right off. You just kind of with the blade and they come right off. That's the way we've removed them in the past. They can be burned off and, anything else that you want to do. Some people just pierce the centers of them and let's get that core out of them. But again, they can be another pesky problem for Dick and Jane. How adorable. Our couples there making the little heart symbol with their hands. So while their love may be forever, while their love may not be forever, their herpes will. So yes, we're switching over to herpes simplex. It's caused by the herpes virus. And the typical lesion starts with tiny vesicles, these like little clear things that you see here, which break down within about 24 hours and then crust over, like kind of what you see over here, one that's kind of crusty. They heal on their own, but they flare up with immunosuppression. So they kind of come and go. So early on, the fluid is where they think the virus is most transmitted. So this is when it's highly contagious. After it's healed, probably less contagious or not contagious. Fortunately, the treatments, although not cured, can prevent these outbreaks. And that's acyclovir or valcyclovir, which is Valtrex. We pretty much use Valtrex. It's an oral pill, and it really does a great job on preventing outbreaks. The treatment I kind of outlined for the oral. So there's different therapies for whether it's initial episode versus recurrent versus suppressive. And if you're not familiar with the medication, you can kind of look it up on it. But I put the information up on the slide just for people that want to read through slides, but I'm not going to. But the bottom line is this Valtrex really can do a great job at preventing outbreaks. Now, the one thing I did mention, when you're having an outbreak, it's the time it's most transmittable. So make sure you don't have sex, definitely not unprotected sex during an outbreak, and let your partner know if you've had herpes. It's, I think, the right thing to do. I know it's the right thing to do. So is there such a thing as safe sex? Well, there is. If Dick and Jane want to play it totally safe, monogamy between two virgins probably has a 0% chance of contracting an STI. But how realistic is that? Well, if we ask Dr. Feiner, who did a study of premarital sex trends in the United States between 1954 and 2003, his conclusion was almost all Americans have had sex before marrying, and goes to make the point that virginity in marriage is probably on the verge of extinction. So, although that's a great way, it's not the way that we tend to see it, at least anymore in the U.S. So, food for thought. Also, by the median age of first-time intercourse has gotten younger over time. According to a 2016 study by the CDC, the average age of boys to have sex is 16.8 years, and for girls, it's 17.2 years. And the number of high school students who've had sex is 48%. Now, that's a scary figure if you've got teenagers at home or teenage grandkids, like some of mine are getting up into that age. Now, in 2019, the CDC did another study of they call the Youth Risk Behavior Study, and looked at a few other areas. But interestingly enough, the number of high school students who had sex went from 48% down to 38%. So less of them have had sex. Probably good. Although I do have a theory for why that is, which I'll mention shortly. However, they also asked them about the use of condoms, which wasn't checked in the previous study, and found out that 46% didn't use a condom. So we're talking safe sex here. and a very vulnerable age. Additionally, they checked, and 10% of students have had 4 or more sexual partners. Interesting. The average number of sexual partners for men and women in the United States, according to a survey that was done by Superdrug Survey in 2018, was a 7.2 sexual partners for men and women. I wonder who's having that 0.2. So now, when Dick has sex with Jane, he's really having sex with her and every Tom, Dick, and Harry Jane has ever had sex with. That's why I make the point of multiple partners being a risk factor in sexually transmittable infections, and something we need to ask about in the histories. So my curiosity led me to find out who holds the record for the most sex in 24 hours. Why I want a sexual partners, not the most sex, most partners. And that's not a real picture. It's an AI generated. All these pictures, by the way, are AI generated. Thanks to my fun with Midjourney. But a porn star by the name of Lisa Sparks, spelled SPARXXX, holds the record back in 2004. She's from Warsaw, Poland, for the most sex partners in 24 hours. Any guesses? 100, 200? No, it's 919 men in in a 24-hour period. That's a lot of sex. Now, here's Dick and Jane, but Dick and Jane are getting a bit older. That's why I use the shades of gray. But even though Dick and Jane are getting older, doesn't mean that they're not being sexually active. About 40% of people between the ages of 65 and 85 are still sexually active, according to a survey conducted by our friends at ARP and the University of Michigan. Now, it's becoming a growing problem. STD transmission in the nursing homes is one of the things that they have to worry about, because it's, again, we're seeing this elderly having more sex and transmitting diseases. And actually, in the nursing home, the 3 most common forms of sexually transmitted diseases are gonorrhea, chlamydia, and syphilis. I told you syphilis was on the rise. And probably some of the factors that have to do with this is the fact that, with the evolution of the little blue pill, Dick no longer has problems with his member. And of course, Jane can go get a Groupon coupon and get a little laser rejuvenation, and she's good to go too. Hormone therapies, etc., things like that. So sex is on the rise, so are STDs. Now, I did mention about why I think some of the reported numbers of sex in high schools went down. And that's because many of the youth and one of our former presidents don't consider oral sex. But as I mentioned in our earlier slides, that is one of the forms of transmission for for sexually transmittable infections. And Dr. Evan Goldstein did a study of oral sex in America, and trust me, it's going long and strong. So it's definitely there. Enough kidding around, enough clowning around, I should say. No, we're not done with Dick and Jane yet. So Dick and Jane want to know, what can we do? We know that probably monogamy and virginity is probably not going to be an option. It really only leaves us with one option that is out there, and that's having some form of a barrier to prevent transmission. And condoms are our barrier of choice to reduce transmission. Now, that's the key word in all this, is they can reduces the risk of sexually transmitted diseases, doesn't eliminate. And I'm curious if anybody else has seen this, but I have, where patients claim to use a condom and still ended up with condyloma around, this is the groin area. So where the condom didn't cover, this is a blow up of the groin area. Well, that's kind of a gross picture. But anyway, that's my point, is that you can even use a condom and still end up getting some of these sexually transmitted diseases, but it's our best bet out there. There is a female form of the condom. This is what it looks like. If you haven't seen it, you're not alone. Only about 1.7% of US women have ever used a female condom. So it's pretty rare. Although I kind of look at this great big wide mouth on it and think that might be a better barrier than a male condom for preventing some of the spread of disease. This kind of shows how it's worn. I've never seen one in the wild myself. This is another thing called a dental dam. This is actually something the dentists use, but it's a thin, flexible piece of latex or polyurethane that can be used as protection during oral sex. And I'll bet this guy wished he would have thought of that. That's not Michael Douglas, but sure looks like him. That's my again being brought up by our mid journey. But Michael Douglas revealed this openly to the Guardian in an article that he had HPV transmitted through oral sex, and believes that was what was responsible for his throat cancer. Now, fortunately, there is something we can do about HPV transmission, and there is a vaccine that can be given. The one that's used now is called Gardasil 9. It has 9 strains of HPV that it vaccinates against. The HPV has about 200 strains, but the 9 that it vaccinates against are the strains that cause the most HPV related cancers and genital warts. It's subtype 6, 11, 16, 18, 31, 33, 45, 52, and 58. I'll test you later on those. So we do have a vaccine. It's recommended for boys and girls age 11 to 12, but you can start as early as age 9. There's a catch-up vaccination recommended for females up to the age of 26 and males up to the age of 21. So it's definitely available and probably good, worth using. I did do some reading up on literature, and because it's now been out for over a decade and people have had the immunizations as a young adult or child, teenager, I guess. Anyway, they've looked to see has there been any cervical cancer in any of these patients who were inoculated with the HPV vaccine, and there hasn't. So it's got some promise. Now, of course, this is still pretty early data because it takes a while for people to develop these cancers, but they're getting up into that age group now where they would be at risk. So it looks like it could be the way to go. So HPV vaccine, highly effective in preventing infections from the strains that it covers. But again, it doesn't cover every strain, but it does cover the ones that are mostly associated with cervical cancer and genital warts. Now, you may have noticed I haven't said anything about HIV, although HIV is a sexually transmittable infection. We don't really deal with it as far as treating it. We send that off to infectious disease. Since I haven't had a lot of experience myself with the treatment of it, I felt it was not something I wanted to talk about. So I do want to mention that is a concern that Dick and Jane need to be worried about. So HIV is out there still. It's a remarkable what things have come around now to help to prevent HIV from becoming full-blown AIDS. So our story's just about over here, but we do have a take-home message for Dick and Jane. Remember, don't be a dick. Use protection. And that is our talk today. So let's bring in our expert crew here. And there we go. Got everybody back on. So what'd you think? Fun with Dick and Jane?
I love the storytelling.
I had a lot of fun with that when I was putting it together. I'm trying to think, how would I, talk about STIs? I've gone to a number of lectures. They're generally, I kind of fall asleep halfway through it about hearing all this stuff. But I know there's a lot of things that as nurses we do, such as the vinegar test. We assist with the treatments. Patient education is huge, especially if you're teaching somebody about Condolex, as I mentioned. So I'll open it up for any questions from the audience, and with the experts, anything that you might have to say.
Well, I think there is something that I have seen. I call it the psychological STI, psychogenic STI. This one story comes to mind. It was a businessman, we'll just call it that. It was a businessman who went to a place down south of where I am, and he was at a meeting, decided to go work out, and then, there's a massage parlor right across the street. So he gets a massage, and then something supposedly happened, and now he's all worried. Of course, he's married. And so he comes in worried about, I think there's something going on down there. Exam is completely normal. There's absolutely nothing wrong with him, but he is mentally worried because of He thinks something may have happened during a brief encounter that does not involve any sort of actual contact that would transmit any disease, but he was worried. So the moral of the story is, don't even get yourself involved in a situation like that. Avoid situations where something like that may happen, especially when you're married. Come on now.
Yeah, we
What's
call
that,
that
the
in
old-
our clinic. We call that in our clinic the guilty dick syndrome.
Yeah.
That is very true. That is very
There
true.
was
And also,
an old show. I can't remember the name of it right now, but it was "Don't do the crime if you can't do the time."
Mhm.
so many things that is applicable to nowadays. And
Has
also,
anybody had a great story? I call them our confession stories. I mean, sometimes you feel like a priest almost when you hear patients.
every single
You know
day.
what? I was going to a bachelor party. They had hookers there. I didn't know they were going to have hookers, and they paid for it. Oh, so that made it right, you know. Well, how could I say no? My buddies paid for it. Really?
even though we advocate the use of condoms, there is a lot of poor instruction, if you will. No one ever talks about how to properly use condoms.
Yeah.
And it's pretty simple. And just like coding and billing, if you know how to do it, it's really simple. But basic knowledge is lacking. So first of all, you have to use a condom properly. And that is, you put it on an erect penis, not a flaccid penis. Pretty obvious, but not obvious to everyone.
Yep.
And then after ejaculation, you have to hold the base of the condom and then withdraw. Okay, you don't just linger. You have to hold the base of the condom and withdraw. And that's how you properly use the condom. A lot of people don't know that.
Yeah. And and I've heard of the female condom, but I've never seen one before outside of doing my research on it, and no knowledge of teaching anybody on how to use one. But it looks like it's fairly simple to use. To me, that I think it would be. Yeah. Go ahead.
I always ask my recurrent urinary tract infection patients if they're using female condoms or spermicides, because that can actually increase risk of urinary tract infections. Not a single time has anyone ever used a female condom. So yeah, I don't even know the education on how to use them correctly.
Yeah. Well, like I said, it was 1.7%. I mean, it's super low. So, and to me, it looks like it would be a valid way to do it. But, and this way here, if Dick forgets his condom, Jane can bring hers. It just
Right.
makes sense to me. But
Does anybody here have any experience regarding the mycoplasma, ureaplasma? Is that really considered a STI, and should the partner be treated as well? Anybody have experience on that?
So I don't specialize in sexual medicine, but since I'm treating lower urinary tract symptoms, I will often offer testing for sexually transmitted infections, especially if there's no positive urine culture on file. And I have seen this before. And I believe I would need to do some research on it, but I'm not sure if it's technically a sexually transmitted infection. I think it's not an STI, but can be transmitted with sexual activity. So I haven't done the expedited partner treatment for that. And if anyone's not aware of that, there is a law in 46 states that allows for practitioners to actually prescribe a medication for the partner without ever seeing the patient. So if I see someone in my clinic who I diagnose with chlamydia, I can give them a course of doxy and write a prescription for their partner to get a course of doxycycline as well without ever seeing that patient. So check in your state if you're able to do that. But yeah, I do see the mycoplasma in my clinic sometimes.
I think the other one that we've seen is trichomonas, where they'll say that can possibly be sexually transmittable.
Yep. And Vic, I was smiling when you mentioned the urethral swab for the males. Once a week, one of my males will say, "You're not going to put a swab in me, are you?" I'm so scared.
That was a standard treatment back when I started. We didn't they didn't have PCRs and things that you could do. It was always send a urethral swab.
We have these younger MAs in our clinic, right? And we had a patient yesterday that needed a chlamydia gonorrhea test. and the doctor ordered it accidentally as the swab, and they're like, what is this? What's that? And the doctor's like, yeah, I need a swab. And he's just kidding, just because he's messing with the younger ones that don't realize that that's what they used to do before the urine test. So,
Yeah. Does anybody had any, or was it a surprise when you heard about the condyloma in the nose from assisting with the fulgurations?
No, in the
No, when
operating
I
room,
was
when in the operating room, whenever I have to use the laser, CO2 laser to burn those, there's a suction right next to the laser.
Yeah. But I
when
think
I
a
first
lot of
started
offices,
assisting,
go ahead.
I was going to say,
You
when
were saying,
first started assisting with this procedure in the clinic, I was working with a urologist who'd been practicing for 50 years. He was very strict about put your mask on, step back.
yeah.
So I was fortunate to be trained by him.
Yeah, that's where I learned it, because the urologist I worked with said the same thing. He said, there's statistics out there. He says, you've got to have a mask on if you're doing this. And N95, he said, because there's people who have had condyloma in the nose. And I'm like, okay, but then I did the research, and, sure enough, this study out of Denmark, now whether they developed condyloma, but they released positive for HPV, that's more than I want. So
I'm going to throw in some comments here that people are putting in.
yeah, definitely.
So Fran said, great job, Vic. Loved the stories about Chicago. And then Nancy came in, and I think she was talking about what Andrea was saying about treating the partner as well. So same in Texas, we can treat the partner as well. And then she also made a comment about have OR background, but good for people to know.
Yeah.
So
the other statistic that really got me was when I was looking at the first age of sex for kids, at 16, 17 years old. I'm like, that's kind of scary, because I got my oldest grandson is 14.
well, you look at the way that, these younger kids are dressing nowadays too, right off the bat. I mean, you're looking at these young girls that are, wearing midriffs and, very short. When we were kids, well, at least when I was a kid, you had certain rules about what you can wear and how long your shorts had to be, and just not looking so, sexual. So, yeah. And even the music, songs, the movies that are out, TikTok, social media, everything. I mean, you can learn everything about sex just by watching social media. I mean, it's ridiculous.
Yeah, it is. It's
I'd be
scary.
curious to know, what does sex ed look like these days in the school system?
Right.
Yeah. Hopefully it's teaching what John just went through, how to put a condom on. I don't think we're going to stop the early experimentation in sex, but we got to do something to stop the infection, especially raising, the rates of syphilis are going up. I mean, that's crazy. That was almost a gone disease.
Yeah, HPV and oropharyngeal cancer is not an insignificant risk. A lot of people need to realize that. Also, I don't know about you guys, but I in my clinic, we don't really treat a lot of STIs. We delegate those to the primary care and the local health clinics. But if you were to Google scrotal pain or epididymitis, it'll say STI is highly associated. But in my clinic, I just don't see a lot of STIs associated with scrotal pain or epididymitis. I see a lot of guys with scrotal pain, but 99% of the time, it's not an STI. There's no history. There's no physical exam findings, and for me, in my clinic, we just don't see a lot of epididymitis associated with STI.
Yeah, even the research suggested that it can happen, but it's pretty rare. So that was, I think, chlamydia. They were saying, because it can cause infertility from chlamydial infections to the testicle.
And I know, we talked about sexual education among young kids. I think a lot of us are still stuck in the old way of sex involving penis in a vagina. And I want to remind the audience that sex does not always involve the penis in the vagina. As a matter of fact, a female orgasm most of the time does not include a penis in a vagina. Yeah, you might be thinking, what? Mind blown. For the guy, there truly is orgasmic inequality. most of the time in sexual activity, most of the guys will achieve an orgasm. But for a female, that is typically not the case unless there's good communication between the partners. And the thing is, during sex ed, they don't teach you about proper, first of all, anatomy, number one. Number two, sexual organs, clitoris, highly sexual, highly sensitive, female equivalent of the glans penis. They don't talk about that. They scare you regarding these STIs and pregnancies, but comprehensive sexual education needs to happen when we're much younger.
Yeah. And I think that's one of the things when I was doing the research, they were saying why the rates of intercourse, because it was looking at vaginal intercourse, went down. And it's because the kids don't consider oral sex. And that's what they're increasing. But again, as we said, it's transmissible. It's not going to necessarily, as John just mentioned, it's not going to make you free of possibly getting something.
Mm-hmm.
I had a patient who had that misconception too, came in and said, I got it. As he was, John has said, the guilt comes in. I got a blowjob the other night from somebody I didn't know at work, at a work party. And he goes, I know I must have something. How do I get it checked? But you can't take and say, well, you're safe because it was only a blowjob. It's oral sex is still a transmission. And as we say,
and it is true with the older population. I do see that. I do find sexually transmitted infections in patients who are older. So keep that in mind.
Yeah. We've had several people come in, ignoring these condyloma, genital wart lesions that are like huge, and they're, and I'll never forget this. And we were excising one time, and the doctor had asked the patient, what made you wait so long? Like, this thing is, ginormous. And he's like, oh, it's okay. My wife just thinks it's the French tickler. And I was like, what?
Like, oh, by the way, you better send your wife over to get
right. She probably has plenty herself now. So
exactly.
Yeah.
Speaking of untreated condyloma, I can remember there was a patient who asked for FMLA after condyloma treatment. And I said, no, you don't need FMLA for that. Yes, he really did, because the excision was so extensive.
Wow.
So yeah, that can really have some large lesions.
Yeah. And then,
and if
as I said, it doesn't go away. Even if they got it treated, excised, all that therapy, the virus is still there.
Mm-hmm.
If you're a provider who treats sexually transmitted infections, there's a great resource that I use commonly, and that is the CDC Sexually Transmitted Infection app. It's really easy to use. You can just pull up the name. It'll tell you what the treatment is, and it'll tell you what the alternative treatments are if the patient's allergic or there's a contraindication to the primary therapy. Remember to tell your patients, if you're treating them for a sexually transmitted infection, that they have to abstain from sexual activity during treatment. Their partner needs to get treated, or they'll just keep passing it back and forth.
Yeah. And you think it's, again, common sense. There's no such thing. You have to tell patients.
Mm-hmm.
Especially, has anybody had any of these issues with the Condylacs where they burn their scrotum from it? Have you seen that? I mean, it's terrible. I mean, that guy come in, his scrotum's beet red. And I'm like, dude, what'd you do? He said, well, I really put the stuff on heavy. I wanted to get rid of these right away. I says, even though I told you not to, right? And he says, I don't think I let it dry long enough. I'm like, no, you didn't. I mean, it was terrible. So that patient had, and you imagine if you didn't tell the patient to do that, how many patients could get injured from it?
Yeah, you asked the question, why do people wait so long before they seek treatment? Well, why do people wait so long before they come in with a huge hydrocele or worsening trouble urinating due to BPH? Chronic gross hematuria. Why did they wait so long? They think,
well, mostly because a lot of them are guys, right?
Oh, yeah. Burying their head in the sand is going to make things go away. No.
Yeah.
Yeah. Most guys wait till they're being taken in by an ambulance for their first doctor visit.
Yeah, you've got like one extreme to the other. You got the people that make a mistake and think they've got every disease in the book, so they're running in, and you've got the one that waits forever and comes in really late. So yeah.
If we only could find the middle of the road patient,
right?
They just don't exist.
Right.
Well, hopefully with education and discussion, people will understand the disease process.
Yeah. And I think that's the most important thing, is getting the understanding out there and being aware, that we need to educate our youth that this is something that they're going to be encountering probably at a time of their life that they're really not prepared to encounter these situations. And they not better that they don't be afraid to talk about it and get treated. And then early vaccination where we can, prevent it where you can really prevent it is important.
There was a skit yesterday that I saw that said, I feel bad for these sex ed teachers nowadays, because it's not just the birds and the bees, it's the bees and the bees and the birds and the birds and the birds and the, so I mean, you're talking about different types of sex, not just intercourse, with depending on who you relate with. So it's a lot more difficult nowadays.
Well, very good. I don't know if we have any other questions from the audience. Nothing. Well, this was fun. I like I said, I was always trying to think of something that we haven't talked about on our show before, and I thought, let's come up with some fun way to do it. So I'm glad you guys enjoyed it. Glad it was entertaining. And next week I won't be speaking. Thankfully, I have this going on.
Certification, offered by the Certification Board of Urologic Nurses and Associates, is a prestigious credential designed for professionals in the field of urologic nursing and patient care. Achieving certification signifies a high level of expertise and commitment to excellence in providing care for patients with urologic conditions. Holding certification demonstrates a dedication to ongoing learning and staying abreast of advancements in urologic nursing practice. Employers often value certified professionals for their specialized knowledge and competence, leading to enhanced job prospects and potential for career advancement. Join us as CBUNA President Anthony Lutz discusses how you can become certified.
That's right. So next week, Anthony Lutz will be joining us. He's from the Sabuna Certification Organization. I got to talk to him at the last SUNA meeting. Real dynamic guy to talk to, and very energetic. He's really pushing to get everybody, certified. So I said, hey, come on the show and tell him how it's done. So he's going to come on our show next week. All right, folks. Well, it's been a great show. Appreciate all your help as always. And we'll see everybody who's available next week.
Thanks.
Bye-bye.